Welcome to the EAU podcasts. In this episode, UROONCO BCa Chief Editor, Dr. Pradere, talks to Professor Vulsteke on the Phase III KEYNOTE-905 study.
Dear friends, dear colleagues, it's my pleasure to be at ESMO 2025 in Berlin again. I have the honor to be with Professor Vulsteke, who is a uro-oncologist in Ghent, Belgium, and he presented in the presidential session the KEYNOTE-905 EV303 regarding EV pembro in neoadjuvant therapy and perioperative therapy. Thank you very much for being with us today. It's really a great pleasure. We have seen a lot of things during this presentation, and I'm really happy to be with you today. Can you tell us about first the rationale and the concepts of the study and how it came to perform this study?
Just going a little bit back to 2023, there we presented also the study, the phase 3 study in the first-line metastatic setting with the transformative results of EVP versus classic chemotherapy that really changed the landscape. We saw there 30% complete responders that after 2 years, you have 75% of chance that you're still in a complete response. So maybe patients with lung mets, visceral liver mets, or I still have these patients that are in complete remission, maybe some of them be cured. And also we doubled the median overall survival there. So it seemed reasonable to bring this drug into the early setting. And that's what we did in the periop, the study you mentioned, the 905, the KEYNOTE-905. And we added that third arm during the trial. So indeed, it's initiated in 2019. But based on these results, we added a third arm. We changed the statistical plan. We prioritized the EVP versus the pembro. It was like a subsequent study. We did that at that time, but I think it's the most honest because that was the changing landscape. So, and at that time, I think it's very fair that we added that third arm, and it would have been hard to start a new study. So today we present these results in this MIBC population, clinical stage T2 to T4A and 0 and 1, non-metastatic, predominant classic urothelial pure urothelial variant, also cisplatin-ineligible part of the classic Galsky criteria, like most of us are using, but modified for peripheral neuropathy because EV is also giving polyneuropathy, and we stratified by region, by TNM stage, by cisplatin eligibility. This was the results we presented today.
Thank you. And so regarding the design, so before we go to the results, to have an idea of how many cycles the patient received before then the cystectomy, and then they were receiving again EV pembro. Can you remind us how many cycles they were receiving?
So in the pembro was given for 1 year. So three cycles before, 40 cycles after the surgery. And this was the treatment plan. And what we see at the end of the trial, that the median number was indeed 3 before, and we have the total was 12 after. So for pembro, it seems that it was reasonable to give this to the patients. And also for the EV, the median number of cycles was 3. That was actually given. It was also the treatment plan to give 3 of them. And after the surgery, we gave 6 of them. And also the median number there was 6 cycles given. And this was based, so 9 cycles of EV in total. This was based on the metastatic setting, where the median duration of treatment was 9 cycles. So we put the same into the curative setting. But indeed, like you have seen, of the 170 patients in the EVP arm, we lost 21 to surgery, so we have 149 patients that actually undergo surgery. And of these 149, only 100 started the adjuvant treatment component.
And regarding the endpoints that have been chosen, primary endpoint was EFS, and what were the secondary endpoints?
The primary endpoint was EFS, and it's indeed important to mention there that EFS was not only recurrence after surgery, but also if you have, for example, if a patient didn't want to go to surgery and we have still muscle-invasive bladder cancer disease, that was counted as an event. If the surgeon tells us there's metastatic disease while operating, he sees peritoneal nodules, it's also counted as an event. If there's during time any high-grade non-muscle invasive urothelial cancer, it was also counted as an event. But most events were recurrence of disease. And the patients that did not undergo surgery but had a perfect clinical complete response, good MRI, and they were informed about perfect status, they were followed up for an event and censored if they not meet the criteria of an event. So only the early censoring only took these patients not undergoing surgery and not having an event. And so the secondary endpoint was overall survival, and a key secondary endpoint, and also the PET-CR rate.
Yeah, very interesting. And so here we go to the results that were definitely impressive, I would say. Can you tell us first the primary endpoints results on EFS, and then the secondary endpoint that we also look at, of course, especially as a surgeon, the pathological complete response rate and DOS?
So the median was 15 months in the control arm, but not reached in the experimental arm. And this translated in a statistical significant hazard ratio of 0.4. So this is strikingly positive. But you always want an overall survival hit also, especially in this perioperative setting. And there we also have already a hit with a median overall survival of 41 months in the control and not reaching the EPP arm. Also translated in a statistical significant hazard ratio of 0.5. So, and to bring it a bit in perspective, for EFS, for example, at 2 years, 39% is event-free. And in the experimental arm, this is 74%. So this is a huge difference. And then for the overall survival, if you look at 2 years, it's 63% alive at 2 years and 80% in the experimental arm. And then looking at the PET-CR, so as a medical oncologist, I go the 5 days after the surgery to the patient, and he asked me, do I still have a tumor in the bladder resected? Did you already looked with the pathologist? And so he asking about APT0 and 0. And we assessed that. And before I say the result, it has to be stressed that the denominator, all these patients, and we have, for example, 14 patients are early censoring, and 10 of them have a perfect clinical complete response. But these are counted as non-responders. So I think it's even higher in reality, but we have to be honest, so we don't know it. So in the denominator, we had ITT population. And by doing this, it was 57.1% with APT0 and 0, so even non-carcinoma in situ, nothing at all.
Yeah, so nearly 60% of the patient had a complete response, which is dramatically an improvement for all our patients, and basically improving by 50% the overall survival and 60% the event-free survival is definitely a game changer. That were the first impressive data. Regarding the toxicity, as a medical oncologist, you're already used to have EVP on a regular basis in first line now, but before in deeper lines. The question is, how was this toxicity for the patient before the surgery, and was the surgery more difficult for the surgeons?
First of all, based on the metastatic setting, also for the med-onc, you need some experience. This is a great power in hands, this regimen, but it's two things you have to remind. It's skin tox in the first cycles, and in the longer run, it's polyneuropathy. And as a doctor, you really have to look to your patient. Also, the med-onc have to look in the folds, in the groins. And if there's some skin tox there, you have to act on it. And if you know this, and you're in safe hands for your patients. So we did that. We saw the same tox as in the metastatic setting. The skin tox and the polyneuropathy were the most common toxicity, but it didn't delay surgery. It seems even that didn't worsen surgical complication rate. So all the AEs, the surgical phase leading to death, high-grade AEs were all similar and very low. So I think EVP did not delay surgery in this population.
Thank you very much. So I think we have understand that this is a game changer trials that you have presented yesterday. Congratulations again to you and all the team and all the patients for this really beautiful trials. I may have last maybe 2 questions. First of all, do you think this treatment would be, so for now it's for cis unfit patients. Do you think it will be available for most of the patients that are cis unfit, or do we have to do a selection? In patient characteristics, 78% of patients had T3, T4 disease before the surgery. What do you think about the patient selection for this specific treatment?
Well, in fact, 70% of patients had the clinical T2 because the investigator assessment was just the opposite. So what we did in this trial, and this is the first trial to date, we sent all the samples for central pathology, and we sent all the imaging for central imaging. So this is a bit scary that you see by central imaging, which rigorously look at perivesical extension and to involvement into adjacent organs to have a clinical stage T3. There it was 75% having a clinical T3, but when you look at investigator TNM baseline, it was 70% clinical T2. So I think this underscores the need of a standardized way, especially in the context of clinical trials, of staging a baseline TNM. And I think based on this trials, how should you select? Well, we have to be honest, 15% were cis-eligible, but it's a cis-ineligible trial. So if you use this already for the cis-eligible, you can imagine it will also work, but we have to await the other trial, that's the B15 trial. So I think this is, I can only say this is a cis-ineligible trial. Can you leave surgery away? I can only say in the trial you needed, it was mandated to have surgery. So I cannot say based on, but I think it paves the way to surgery-free regimens in this population.
Yeah, I think you open a lot of questions that we have after these trials. And indeed, I believe that probably we will see more patients at our consultation refusing to get cisplatin, because then they can enter and fit into the KEYNOTE-905 trial and get EVP. So that's potentially something that we're going to see in the next coming months for the patients that are well informed. And regarding the question of will we have, well, we have to already look at, will we be able to tell our patient to avoid the cystectomy, to not go through the cystectomy? So far with the trials, we can't, but we will probably face more patients that will ask for bladder sparing strategy after EVP. Maybe you have one or two insights regarding bladder sparing strategies that you may see as potential after EVP in neoadjuvant setting?
Well, I think it will be hard to randomize against cystectomy. At least in my practice, I cannot sell this to the patient. I think we have to start as soon as possible. This well-conducted single-arm trials, maybe biomarker-driven based on pathological response. But we need them now, because otherwise in the real world, it will be adapted without that evidence. And that's also not good, because this trial doesn't say, it paves the way, but it doesn't say you don't need surgery because it was mandated in the trial.
I think you're very right. And biomarkers will also help us a lot for the next coming trials to pave the way for bladder sparing strategy for these patients that are a complete response. Thank you very much for your time. It was a pleasure to have you here at UROONCO podcast, and we look forward to have you again.
Thank you. My pleasure.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform, UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.